Hello, everybody, and welcome to this edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Stephen Tamang. Doctor, thanks for hanging out with me.
My pleasure.
Here on the podcast. Now, we were talking a little bit before we got started, and you're in effect a local, right? I mean, born and raised in Montana.
Yes, sir.
You're familiar. Did you ever spend time? Well, Great Falls. I mean, how often did you ever get out here when you were growing up? Really?
Never. It was entirely my wife's fault that I'm here, but I'm happy to be here, and I've since moved my parents out here when we had kids. So
really,
yeah, we're pretty locked in and happy to be here.
Well, that's awesome. And you've been here about a decade, I believe you've said. Okay,
yep.
So you've kind of made it home, and you're familiar with everybody for sure. Well, the reason why we wanted to have you in here today, Doctor, was to talk about something that I know you are extremely passionate about, and something that Monument is kind of getting off the ground here as well, and that has to deal with addiction specifically, correct? How did you fall into this, or why did this become such a passion for you?
Well, initially, as an outpatient doctor, I encountered an awful lot of folks who had addiction, and I realized that if you're trying to make a big impact on someone, it's pretty low-hanging fruit. And so just through keeping up with the changes that have been quite rapid in the field of addiction medicine, the treatment modalities got really effective. And so I just started doing more and more of it, and when you do it and you have good results, you end up getting more referrals. And so it just grew into unexpectedly a fairly large portion of my practice. And then now, as I've moved to a hospitalist, it's become apparent that in the hospital world, it's a very significant need as well. And so I was grateful that the Monument folks at the executive level really wanted to expand that and start addressing addiction kind of throughout the whole system.
Did you have personal experience with this? Was there something in your background that brought it around too? I mean, if you're comfortable talking about something like that.
You know, I've got the most boring background ever. Thankfully, I have not, by the grace of God, I have not fell victim to any particular substance use disorder. But of course, just like almost everybody, I know people that have, and some of the smartest, brightest, hardworking people that you can imagine that have. And so and then of course, just professionally now, having really been involved in this for a long time, I can think back on patients that, it's claimed their life, and it's such a shame. It's a terribly painful thing to lose patients from addiction, when organically outside of that particular issue, they're very healthy, functional humans. And, I think the average person can really relate to that when they look at some of these very influencers, very famous people. Matt Perry was he made
absolutely.
People loved him, and it was clearly alcohol use disorder that ended his life. And so when you kind of look at that, people can relate to that. And so personally, I've seen so much of that now. I feel like it's kind of burned into my psyche. So yeah.
So do you feel like, and maybe it's just because the social media and the internet and how we are so connected anymore, has there been a rise in addiction? It seems like it's just almost out of control in some instances. Do you feel that way?
So the change in addiction over the last, I'd say 20 years or so, has primarily been around opioids.
Okay.
And that's why you hear the term opioid crisis. And unfortunately, that process resulted in a lot of secondary addictions, because as you had a large group of people in the 90s, late 90s, early 2000s, get addicted to opioids because they were being massively prescribed, and we can get into that for a lot of different reasons. You developed a populace that had an addiction problem. So a neurobiological issue had arisen due to opioid exposure. And then over time, we got a lot smarter about, we shouldn't be prescribing so many opioids. And law enforcement got smarter about heroin. And so people from that initial population turned to other substances. So obviously, it's more nuanced than that, but a big piece of it is the rise of opioids subsequently fueled other addictions. I have many patients that turned to stimulants, primarily methamphetamines, because they were under so much of a craving or a jonesing, maybe you would say, for opioids. They try to scratch that itch any way they can. Alcohol, it's a very destructive pattern. But so that's really been the biggest change. Then there's some others that have been kind of interesting that have just sort of technology driven, like vaping was kind of something that came up for a while, and that was interesting. But overall, the trend got pretty bad. But I think we're at a reflection point right now, and I'm pretty optimistic about the future.
Well, really quick, for people that, and I guess I'm not super familiar with what an opioid is.
Sure. So you think of it like a painkiller.
Okay.
And so an opioid, or opiate specifically, it binds a type of receptor in the CNS, central nervous system, and it diminishes pain. And the reason why it's potentially fatal is because in high doses, it is quite a sedative, and so people stop breathing. And so that's why you probably have heard of people getting like Narcan, the ambulance drivers. So that reverses the opioid sedative effect. So you hear about people waking up, after they've taken an overdose of an opioid. So heroin is an opioid. And so that's why it was particularly fatal. A lot of the other substances that people historically have abused did not have that level of lethality.
Right.
But fentanyl, obviously, the synthetic opioids, whole nother ball game. It makes heroin look like nothing. And so the mortality was much higher.
Well, I'm assuming that when opioids first became a thing, they had to have been something that doctors were excited about.
Oh yeah.
Because they realized that they could help people with that traumatic pain. Correct?
Oh yeah. Opioids have been around forever.
Right.
It's not a new thing. Morphine was around, forever, and in the various forms. Morphine, go to a dentist, you get Vicodin or Tylenol with codeine, or you have surgery, you get an opioid. It was really in the late 90s that the pharmaceutical companies, they started developing some very novel approaches to delivery. It's kind of the bioavailability and the pharmacokinetics of these drugs changed, and it was through just a horrible Swiss cheese of missing the safety marks that they became highly prevalent. There's a lot of great, Hollywood, I don't know if it's Hollywood anymore, but Netflix and Hulu, there's some really great series now, describing these. The names are evading me, but I know there's.
Oh yeah, I mean there are.
Yeah, they're very. They talk about the Sackler family.
Yes.
And Purdue Pharma, and they're shockingly correct. And if you just read about, you go to the Wall Street Journal and you can search the Sackler family.
Oh, I encourage people to definitely look into that. It's fascinating. That whole really family was. Oh boy, are you going to go to some dark places, really?
Yep. And so it was late 90s where they started developing these. I think the classic one is OxyContin, and they came out with a series of products that made people feel great. I mean, opioids make you feel great, and in the right circumstance, they're a wonderful tool. But obviously, they carry not only fatal in high dosage, but they also carry severe addiction potential. Now, the studies that came out that were sponsored by the drug companies, they were actually decent studies. This is where it got tough. The studies that were done were peer-reviewed in respected journals. The problem is they had the wrong conclusions, which we know now. So medical research obviously is not perfect. We can identify studies that we have now saying, okay, these were all wrong. But they were able to leverage those studies to get approval from the FDA for non-addiction. They came out as lower class of addiction. So and then it got worse because you had government bodies like JACO who oversee hospitals and say, we're going to make pain a quality measure. So if you're in the hospital and your pain is not being addressed and treated, which almost always with an opioid, we're going to ding the hospital for that. That's so. I remember when I was a resident, when I presented a patient during rounds, I had to say the patient's pain score on a scale of 1 to 10, and if it was above a certain threshold, is what we're doing about it, which was almost always an opioid. And that was because of the FDA's decision based on studies that were wrong and probably quite a bit of influence from the pharmaceutical companies. So that created that perfect storm, created the birth of the opioid epidemic.
So what when you're talking about that, and I'm thinking of opioids, and you keep talking about the severe addiction, what causes that addiction? What in that little pill that you take? Why is it so highly addictive?
Yeah, it's all about dopamine. There's a lot of different aspects that cause you to have an addiction, but the most basic and the most powerful is when you take anything that causes a pleasurable experience in your brain or a dopamine release, you create a wiring, or in technical terms they call it the neurobiology reroute. And what your body begins to crave is an additional dopamine surge. And so when people, if you took a small amount on a short time and you weren't genetically predisposed, it's very unlikely you would obtain an addiction. But if your prescriber wrote you for OxyContin for 30 days every day, it is very unlikely you would develop an addiction.
Right.
And so all of a sudden, from your brain's perspective, getting an oxycodone is more exciting to you than eating a good meal, having sex, getting if you inherit a bunch of money or you get a windfall, like you get a little dopamine rush, the opioid would be more important to you than that. Like it's that level of craving. And, you can try to fight it. Like the frontal part of your brain allows you to have volition and control. And you're like, intellectually you can say, this is a bad thing. I don't want to take it. But the primitive part of your brain is telling you this is the most important thing in the world. Your kids don't matter. Your job doesn't matter. This is what you need. And it's a terrible battle. And once your neurobiology is routed in that way, that process stays for a very long time. And for some folks, unfortunately, it stays permanently. And so what we try to do is introduce pharmacology in addition to behavioral methods to try to manage it. But for the majority of folks, once they've had a rewiring of their neurobiology, it's a lifelong process. And you can encounter this, like if you've ever seen AA or, it's a great peer support group. But the thing that is very useful, I think, for most folks to recognize is even after you've been there for years, they're still sometimes struggling. It's not like, okay, I made 90 days, I'm good.
Right.
Many of those folks, they still celebrate their anniversaries, like, still going, because it's still a battle.
Well, if you've ever tried to quit smoking,
exactly,
you'll know exactly what that feeling is too.
That's right.
23 years ago I did, and to this day, you still have those moments where you're like, boy, a cup of coffee and a cigarette, my God, that'd be good right now. You know, so I can't imagine on something like an opioid or fentanyl or something like that. When you can still have those little cravings after that long on something as simple as cigarettes. Well, not simple. They're terrible for you. We know that. I can't imagine what it takes to get out of that. And I suppose a lot of this too, for people that struggle with this kind of addiction, that they know they're addicted and they know it's going to be a problem, there's got to be a stigma that goes along with this too, that you guys have to fight as well, don't you? Oh, sure.
And it's interesting to kind of talk about something you mentioned in regarding to like comparing substances.
Yeah.
A lot of science has gone into trying to figure out like what makes a particular substance more addicting than another substance.
Yeah, that's really interesting.
It is, and we've gotten a lot better about it. We're using a lot of techniques now. Functional MRIs are being utilized to try to determine like which substances lights up the pleasure centers of the brain, and then equally important down the road, which brains look more deprived of dopamine, because it's not just the surge. You'll get a surge when you use your substance, but then afterwards your dopamine levels are far lower than the average human. So in those studies, this is interesting because they can now accurately and reproducibly compare dopamine surges among multiple substances. And so if you look at it, opioids are up there, but cocaine is up there. Tobacco is up there, and then they put it against other things. They put it against food, they put it against sex, and those are there as well. But when you look at the numbers, by far, methamphetamine is incredibly addicting. Now, the difference between meth and opioids, meth is not nearly as lethal. So, like when you look at our populace in South Dakota, meth is the biggest prevalent problem. Mm-hmm. But the lethality of methamphetamines is much less.
Why is that?
It's the neurobiology. It is incredibly addicting. So just to give you scales, say like you and I say just baseline, we're at 100% normal dopamine level. If you take an opioid, you'll go up maybe to 200 to 250. Similar, if probably a little less with tobacco or somewhere around there, depending on what studies you're looking at. Cocaine gets you a little higher. Methamphetamines will take you up to 1,800% or so. So not only does methamphetamine cause a dopamine surge, it actually binds to a receptor and you can think of it, it spins it backwards. It releases as much dopamine as your body, that part of your brain can make, into your neurobiology circuit, and you feel, I can't imagine how you feel. It must feel amazing.
It has to.
Yeah, and the level of addiction is severe with meth, but the lethality is much lower. And so that's why in our current situation, you see so much methamphetamine use. If they had the same level of addiction to opioids, they would have died. Like the overdose would have brought the population in that regard down.
What is the biological function of dopamine? Why is it so important?
Yeah, it's key. It's one of the kings. So like epinephrine, norepinephrine, dopamine, serotonin. Like it's a neurotransmitter that if you didn't have, you would not be a human. Like if you're happy, your dopamine levels rise.
Right.
And a lot of the pharmacology that we use to treat depression modulates dopamine. And it's complicated and beautiful. But when it gets out of its normal ranges, it can cause several psychiatric conditions, which is why many times when you see folks who abuse abuse substances that cause dopamine, you see psychosis induced from, like, I'm sure you've encountered or heard of, methamphetamine associated psychosis. Mm-hmm. Like, this is a very common thing where patients appear just very much like a schizophrenic or schizoaffective. They loud, argumentative, talking to themselves, pressured, manic, that kind of thing. And that's a dopamine response in relation to chronic neurobiology damage from the stimulant. So it's a great thing, but when it gets out of whack, it causes a lot of diseases, and not much gets it worse than methamphetamines.
So we still need something, though, in your profession for people that you've talked about depression, people that go in for surgery with chronic pain. There still needs to be ways to fight this, correct?
Absolutely.
So where do we go then? What's next for it?
Yeah, we as medical community and just humans, like, we've gotten much better at this. And the opioids are now much more appropriately scheduled.
So you can still get prescribed opioids.
Of course.
I mean, they're not. We're not removing them from the arsenal.
No, and that's an important point. Like, I think some people argue we've gone too far. We've made them too restrictive, and every now and again you'll hear stories about people that have terrible, debilitating syndromes, and they weren't given proper pain control. And so I think the pendulum, was at one point where anyone with subjective pain gets opioids. Mm-hmm. That was obviously insane. And then it swung over to, like, we're kind of scared of them, because it's funny, you can look at news articles from like the 90s, late 90s, where doctors were getting sued because they were not prescribing enough. They were like, people were dying of something, and the doctors weren't prescribing enough. So they're getting sued for that. And then you fast forward a decade, they're getting sued because they were prescribing too much. But we're a lot better at that now. Mm-hmm. And I think, any reasonable provider is going to know that an opioid has its place. And thankfully, I think most providers now are starting to recognize, opioid use disorder is a consequence, of neurobiologic change. And so it's really a disease. And so we have options to treat it. And as you alluded to, stigma was a big deal. Like, I think earlier on, you would look at a disease like, okay, someone who had a problem with opioids, and somehow that wouldn't be considered the same as, someone who had a problem with, like, high blood pressure. when in reality, they're both, if you look at it from like just a paper standpoint, they're both chronic diseases. They both require chronic management.
Right.
But somehow, because it is related to something potentially more illicit initially, or not even necessarily, those could have been prescribed, but worse social standing, that somehow it is classified as stigma. But we're getting better there too.
Well, I know I think the last time I was prescribed an opioid was having a wisdom tooth pulled. But going back to the stigma, I remember getting the prescription, and this was, kind of at the height of the everybody was getting opioids. I'm like, I don't know if I want to take them, and I think that can be a problem though too with people that hear the horror stories and think, well, first time I take one of these, I'm now an addict, right? And I'm not going to be able to break out of this. And that was a little bit my fear. So I was like, well, I guess it's ibuprofen for this. It hurts like hell, but that's all I'm going to take, right? So I think that has to play into it too a little bit. People just need to sit down with you as a doctor and understand the process. And with Monument Health now, can you talk a little bit about what is happening there and your role and what changes are coming, or what you're seeing that's exciting?
Yeah, I think nationally we're seeing a very positive change. And I think it stems from the fact that we have tools that are effective. As I alluded to before, when you compare a substance use disorder against other chronic diseases, JAMA is a very respected agency, I guess, and they've published on this quite a lot. And you can compare if you have, for example, alcohol use disorder or opioid use disorder, and you have those patients under evidence-based care, the relapse rate is favorable or equivalent to other chronic diseases. And that's really because the FDA has gotten some stuff right. We have medications that can help. So you mentioned smoking before. Like some people, really benefit from Chantix. Some people really benefit from, Wellbutrin for that, or nicotine replacement products. And so that's an easy way to think about it for people that have opioid addiction, or people that have alcohol use disorder, or some of the other things even that are kind of out there, some of the folks that struggle with, hallucinogens or dissociatives. There's tools that you can use that actually work. And so that's the change. And so once that kind of got realized, I think the mindset started changing. And so you see addiction medicine now as a medical subspecialty, and it's growing exponentially.
Right.
Because all of a sudden, the health systems are realizing, hey, we can take a lot better care of patients, which is obviously in their mission. But as a side of that, you actually make the system work a lot better, because addiction has a terrible tendency to not only ruin a person's health, but socioeconomically destroy them. And they end up becoming very heavy, inappropriate healthcare utilizers. So
right.
if you throw up a Venn diagram of inappropriate healthcare utilization with patients who suffer from substance use disorder, the Venn diagram is basically like this, almost the same. And so health systems, I think, across the country are recognizing that if you can even make a small dent, which practically speaking, you can make a pretty big dent with minimal effort, you can not only help the system do better, but more importantly, you really make a difference for the patients. And then that really spreads out to the community, because every person who struggles with substance use affects their entire social network in a very, very large way. It's especially if it's like, a parent, it has bad downward effects, or it knocks out some of, very, very useful people for society. It knocks out people that are in business. It knocks out entrepreneurs. It knocks out people who are amazing artists and talented folks. So yeah, it helps the community, helps the system. And so that's why there's been this rise. And so I'm grateful to, it's not just me, of course, but I'm grateful to be spearheading it for Monument. And I'm happy to be here to get to talk about it, and hopefully educate some folks about it.
Well, what would you say, as we kind of wrap this up, what would you say to somebody that might be listening to the podcast right now that is grappling with an addiction, and just, they're worried about the stigma. Maybe they don't have a lot of people that know about it. It's affecting a small group, but they want to reach out. What do you tell them initially? If you could look at them right now and say, hey, here's step one. How do you start that?
Yeah, so this is a conversation that we have a lot. And I think the first thing is just being truthful and compassionate. And that's like, here's the problem. If you go to an average doctor, even now, they're not necessarily going to be in a position to be the most up-to-date on addiction medicine. This is a fact. It's unfortunate. And so what many patients have come, I would say the majority, from my experience, they get their information from social media. Mm-hmm. And it's strange because you think of social media as relatively unreliable.
Can we just say that TikTok is a terrible place to get your medical
advice?
Okay,
it is
perfect,
a terrible
good.
place. And I would never advise anyone going there, but I would say the majority of people get their information from these spots. And it's interesting that the people that have like the most, I follow many of them because I'm curious about the pulse of it. The information that they spit out in many cases is accurate and it's truthful. And that's why you see all these people trying to treat their own addiction. I've had folks, they look me up because they look for addiction medicine. They find me, then they come in and they ask for this regime of medicine. And that regime of medicine was recommended on TikTok. It's like, wow, this regime of medicine is precise and correct. And again, I'm not endorsing TikTok.
Right.
I want to make that clear.
It.
But my point is like, the medical community is a step behind truth in this. We're catching up.
Right.
So when I would see somebody, first thing I would just say is like, let me just explain to you what this actually is, and let me put it in context. So if it's, if they have alcohol use disorder or stimulant use disorder, I'd say, this is why you have these cravings, and despite probably trying to quit 1,000 times, this is likely why you failed. And this is, if they want to know about it, we can go deep into the neurobiology. And if they don't, I just say, now these are the 7 or 8 FDA-approved options that can help you combat this. And then I can lay it out from an epidemiological standpoint and say, it's very likely that there will be a relapse at some point. This is, statistically very common. But that does not mean everything you've done in the past is a failure. Many people feel that way. Like, I was sober for 6 months and then I relapsed. They feel like their whole life is over. Everything they had done is worthless. That's just not so.
No, you went 6 months. Yeah, I mean, that's amazing, right?
Exactly. And it would be the same way to say if you were an insulin-dependent diabetic and then, you became careless and you didn't take your insulin and you had a diabetic, complication or DK or some crisis, that somehow everything you've done before is terrible and you're worthless. And once they get educated, and then so you explain that, and then you're honest, and you don't try to, we've done a terrible job trying to scare people before, which is just insane, and so you're just honest, truthful, hopefully loving, and then people respond to that, and then it's like, okay, I have these meds, I got someone who can listen to me, I have someone who won't judge me if I make a mistake, I have someone I can confide in that I'm struggling, and I know that they're going to be on a framework of reality and not like, wag the finger.
Right.
That makes all the difference. And so it's a process. And younger folks, data suggests that younger folks, they get this very, very much. Like if you talk about addiction with the younger population, they're actually quite smart. They do not want to be addicted to things.
Yeah. Except their phones.
Except for their phones. Yeah. Try to recommend smoking to someone in their youth, they're going to look at you like, that's disgusting.
Exactly.
Get that away from me. And so I'm optimistic about the future, and I'm grateful that Monument's taken this head on.
Well, there's so much more we could get into, Dr. Tamang. So I'm hoping at some point you'll come back and we can talk about this some more. Specific things that I think I have just a lot of things that were popping into my head, but I thought, well, we might have to drill down on those a little bit later on. But again, Dr. Stephen Tamang, I learned the word hospitalist today too, with Monument Health. You do specialize in addiction medicine. So again, thank you so much for coming in and talking with us. This has been fun. I appreciate it.
It's my pleasure. Thank you.